Welcome to EuroPCR 2018. My name is Emanuele Barbato and I have the pleasure today to discuss a very important topic with Michael Maeng from Aarhus University Hospital in Denmark. With Michael today we'll discuss about STEMI in patients with multivessel disease, particularly how physiology-guided assessment of non-culprit stenosis can improve our clinical practice. Michael, the first question I have to you is the following one. Is it safe to perform this kind of clinical assessment, diagnostic assessment, within this context?
Yes, it is. We now have several studies, also large clinical trials, showing that it is safe to use both FFR and other modalities such as IFR to assess the functional significance of non-culprit stenosis.
And how reliable are these assessments within a patient that is coming with acute chest pain, with an ST elevation myocardial infarction? So I imagine there are several ongoing conditions going on. Microvascular function might not be stable. How reliable is the assessment of these indexes and parameters?
We have investigated the trustworthiness of IFR in the STEMI trial, and we found that this method has a very high negative predictive value, which means that if the lesion is non-significant, then you really can trust the result. Whereas we find only moderate positive predictive value with IFR, which shows that some of the lesions that are in the acute phase are positive by IFR will become negative if you follow the patient if you re-examine the patient after 2 or 3 weeks. So this means that you cannot exactly trust the results probably due to edema, to spasm or microvascular dysfunction in the acute phase.
That's very interesting what you're telling. Let me further ask you to better understand what it means, negative predictive value, and how is this clinically relevant to our practice. For example, if I have an IFR value of 0.94, how can this be useful to my clinical practice?
It means that if you have an IFR value of 0.94, it means that the lesion is not positive. That means that it does not have any functional significance for you. So this means that if you do the measurement on the very same day as you have your ST segment elevation myocardial infarction, then we can say that you don't have to come back for further follow-up. You don't have to go through other examinations. I can tell you right away that you don't need more revascularization, that you are safe and to go home.
On the other side, you also discuss about lower positive predictive value with IFR. Is there an issue with timing? Is this something that has to do with a time window where it would be safer to perform non-resting index evaluation?
Yeah, our results suggest that within the first 5 days at least, then the edema or the impact on the microvasculature of the STEMI makes these measurements a little bit uncertain. It still is quite moderately good, but not perfect. So in these patients, you might have to wait for a couple of weeks to get a trustworthy result.
Is there a way to overcome the limitation of resting indexes in these specific time windows? Do you have a suggestion that we could integrate this index with other invasive functional assessment?
Yeah, it seems from the REDUCE MVI study that is also presented here that the IFR has a very high negative predictive value, whereas FFR has a very high positive predictive value. So you can use IFR to rule out these significant lesions, and then you can do, in the remaining patients, you can do FFR to make sure that these patients actually have a significant lesion.
Right. How solid are the clinical evidence in favor of one or the other kind of invasive functional assessment?
Right now we have good data, good clinical data from the Dynamic 3 Primulti trial, and we also have good data from the Compare Acute trial showing that you can use FFR to guide your treatment and have very good results by doing so. We don't have data, clinical data on IFR at the moment, but there are at least one study going on trying to get the same data for IFR.
Thank you very much, Michael. I think you made very clear the point on the need, on the importance of the invasive functional assessment. You, in a very balanced fashion, discussed the pros and cons of using resting indexes versus hyperemic, and there is indeed some room for integration of the two indexes in the best interest of our patient. And last important information that you just conveyed was that so far we have solid clinical outcome data with hyperemic indexes, with FFR, while interesting data are coming up as far as the implementation of resting indexes in the context of STEMI patients with multivessel disease. With this, I would like to thank you very much for sharing your experience and knowledge, and I wish you all the best.